Welcome to our event today, our webinar on diet and non-diet approaches to the low FODMAP diet for IBS. And with that, I'll introduce our speaker today, Beth Rosen, who's really truly an expert in this field. So we're super lucky to have her here with us today. Beth Rosen is a weight-inclusive registered dietitian who specializes in GI nutrition and disordered eating. She's been working in nutrition for over 27 years and has a virtual private practice. Beth helps clients find relief from digestive disorders, including IBS, SIBO, Gastroparesis, Celiac disease, and reflux. She also shares her wealth of experience and knowledge with other clinicians via webinars like ours today, seminars, and peer mentoring. Beth is also the vice chairperson of the Dietitians in Gluten and Gastrointestinal Diseases, so DIGID, the subgroup of dietitians in medical nutrition therapy, the practice group of the Academy of Nutrition and Dietetics. She's also the director of nutrition and dietary services for GI OnDEMAND, which is a really unique partnership between GastroGirl and the American College of Gastroenterology. So GI OnDEMAND provides integrative GI virtual care and support to patients. So in our follow-up email today, we'll share a bit more about this program. It's a really valuable resource for truly all dietitians, regardless of your background or your specialty. Beth has also designed techniques and programs to empower chronic dieters, disordered eaters, and those in recovery from eating disorder to truly mend their relationship with food and their bodies. She's also written for major media publications such as Practical Gastroenterology, Huffington Post, Very Well Fit, and FabU Plus magazine. I really encourage you to visit Beth's website, BethRosenRD.com, to learn more about Beth, her work, and her philosophy. And really with that, I'll turn it to you, Beth.
Thank you so much, Jocelyn. I really appreciate that warm welcome and introduction. Hi, everybody. I'm excited to talk to you about this topic today. Here are my disclosures. And what we'll cover today is a brief overview of irritable bowel syndrome, or IBS, and the most common dietary intervention to manage IBS, which is the low FODMAP diet. And I'm also going to share with you people who are appropriate candidates and inappropriate candidates for the use of this diet, and then give you some alternative information for dietary interventions that can be used with folks that aren't good candidates for this diet, and then some non-diet interventions to also help you if diet altogether is not recommended or in tandem with a dietary intervention. So I want to start by defining what is a functional GI disorder. And it's a group of disorders classified by the common symptoms, which are in combination of either motility disturbances, visceral hypersensitivity, altered mucosal and immune function, and changes in gut microbiota and or central nervous system processing. And this is different than a structural disorder, which may have similar symptoms, but are caused by a change in the structure of the GI system, like an obstruction or damaged villi. So IBS is not a diagnosis that's given when structural issues have been ruled out or if they've been diagnosed, but we have to rule out the alarm features first in order to diagnose IBS. And this is done through, IBS can be diagnosed through the Rome-4 criteria that are related to defecation and include recurrent abdominal pain, a change in the frequency of bowel movements, and a change in the appearance of stool. I wanted to share this great visual to explain what visceral hypersensitivity is, which is defined as an abnormally high sensitivity level to the presence of normal stimuli. So an example of this is that fermentable carbohydrates, which we'll get to in a minute in depth, are poorly digested by all people. But for people with IBS, when these foods are consumed that have these fermentable carbohydrates in them, it can result in an increase in GI symptoms, including pain, bloat, gas, and changes in bowel habits, including diarrhea, constipation, or even mixed bowel habits. For some people, they experience urgency and fecal incontinence as well. So I like to tell my clients that they have a drama queen living in their gut. So the goal of the dietary intervention is to reduce the stimuli to minimize the symptoms. Let's now look at how we can manage IBS symptoms from a dietary perspective. So to date, our best dietary intervention is the low FODMAP diet. And we'll do a quick review, as I assume most clinicians are familiar with this diet. So FODMAP is an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these are scientific names for fermentable short-chain carbohydrates that are poorly absorbed by the gut. Oligosaccharides, or GOS, consist of galacto-oligosaccharides and or called GOS and fructans. There are positive and negative effects to fermentable carbohydrates. So the positive is that they are fuel for the microbes in the microbiome and promote a diverse microbiome, which for right now, what we know is a diverse microbiome is a healthy microbiome. The negative impact for people with IBS is that some of these FODMAPs are osmotic and can draw water into the gut, and some are fermented by the microbes and can trigger symptoms such as abdominal pain and gas and bloating and bowel changes and a whole host of things that just don't feel good. So this is the low FODMAP diet in a nutshell, and this was created by Monash University in Australia. And the low FODMAP diet is a 3-phase diet. The first phase is the elimination phase, and the goal is to remove all possible fermentable and non-absorbable short-chain carbohydrates. And it's a very short-term elimination phase. It's no more than 2 to 6 weeks. And at the 2-week mark, if there is no marked difference, no benefit happening from the diet, then we stop and we abandon ship and we look for other things that may be causing to trigger symptoms, but food is probably not the cause. And if at the 2-week mark, we see a marked difference, then we move on to reintroduction. And if we're seeing a little bit of a difference and the client would like to stay on it longer, they can stay on it for up to 6 weeks before moving on to reintroduction. And the reintroduction phase here, the goal is to liberalize the diet and increase variety and choice, and also reduce food restriction and food fear by allowing foods to come back into the diet quickly. So that's why it's not a long-term elimination phase. And this helps to minimize the risk of maladaptive eating and disordered eating behaviors. And then once they have systematically reintroduced FODMAPs back into their diet and determined which foods are unsuccessful and which foods were successful reintroductions, they can then move on to the personalization phase. And just a note about unsuccessful food challenges, they're not avoided for the rest of their lives. They can be added to the bottom of the list and tried again at a later date. Usually between 3 and 6 months is a good time to retry. And then the third and final phase is the personalization phase. And the goal here is to empower our clients to know what foods, if any, are triggering their symptoms. So we want to understand when a food is or is not playing a role, and we want to minimize food fear and food blame by moving on to this phase. So not everyone is an appropriate candidate for the low FODMAP diet. So it's important that we screen everyone to make sure that they are an appropriate candidate. And appropriate candidates include those who have been screened for an eating disorder and don't have one. Those who are well-nourished, no vitamin deficiencies, no issues with restrictive diets already. And then also those who are open to changing their current diet or food repertoire, and also have an understanding of food preparation and label reading. And this doesn't come easy for everyone. And so the traditional low FODMAP diet just may not be appropriate for everyone. Some of those who would not be appropriate candidates for the low FODMAP diet include those without a diagnosis for IBS. These people we would want to send back to their gastroenterologist for a diagnosis and to rule out any alarm features. Others who are inappropriate candidates include those who have been screened for an eating disorder or maladaptive eating and have been found to have those. Children, who we don't put on restrictive diets, only in certain cases. Elderly without support, and those who are unwilling to make changes to their diet. So we as dietitians can educate and counsel, but we can't force people to do something that they're not open to doing. So these folks won't benefit from a diet if they're not willing to follow it. And finally, those folks who don't have access to low FODMAP foods, or have trouble with food preparation, or difficulty with reading labels, or don't have the funds to go out and buy all new groceries. So as you can see, the low FODMAP diet can be difficult to follow without support and without proper tools. And I should have mentioned before that the low FODMAP diet is most effective when it's administered by a GI dietitian, because it is ever changing. There is a list of foods that Monash University puts out. It changes quite frequently because their research is ongoing, and which is wonderful, but it can become confusing if people are looking on the internet and finding lists of food. So if people don't have access to a GI dietitian, that can also be a limitation to being able to use the low FODMAP diet. Now, this is something that I've heard a few times from other practitioners, and it rings true in my practice as well, which is that if you work with GI patients, then you work with people with disordered eating. Data shows that functional GI disorders in those with eating disorders runs as high as 90% of people. And 41 to 52% of people with eating disorders have IBS. And in addition, just those with bulimia nervosa, 68% of those folks have IBS. It's thought that the disordered eating disrupts the GI system, which makes sense, and that's a whole nother conversation. But we need to manage those symptoms and those disorders before we can treat the GI issue. There are some people that have a GI issue that then end up having disordered eating, but that's only about 16% of people. So it's understood that the eating disorder typically leads into the GI disorder. So we need to refer these folks to mental health professionals and eating disorder informed dietitians to help them begin with their disordered eating recovery before being treated with any dietary intervention for GI issues. Signs and symptoms of an eating disorder are listed here, not in their entirety, but some things you might see or hear from clients with eating disorders is a preoccupation with food or their weight, with calories, with sugar on a label, restricting certain types of foods or food groups or ingredients. They may also be chronic dieters or skip meals, or are hyper-focused on their body size and shape. You may also notice a change in their weight, either up or down or both. And that's something you can see by looking at their records or by asking them if their weight's fluctuated lately. If they have a menstrual cycle, you can ask if they have menstrual irregularities. We also might find abnormal laboratory results and an inability to tolerate cold and dental problems. Or it's possible that you don't see any of this and they don't share their struggles with you. So this is why it's important to use a screening tool with every person that comes to your office. And here are a few tools that you can use. The first one is Eating Attitudes Test, or EAT26, which is a questionnaire of 26 questions to ask your clients or have them complete. It does come with a scoring key, so you can determine if their eating is competent or not. There's also the Eating Disorder Examination Questionnaire, the EDEQ, which also can help to determine disordered eating. However, neither one of these methods is validated for use in patients who also have GI disorders. There's only one that currently exists, and it's just for people with celiac disease, and it's called Celiac Disease Food Attitudes and Behavior Scale. But even with valid screening tools, the only practitioners that can truly diagnose an eating disorder are mental health professionals, because eating disorders are mental health disorders. But just getting some of the answers to these questions, you might see a theme of maladaptive eating behaviors, and that might cue you into how best to treat this client. So should that be the case, and you run into clients who are not appropriate candidates for the low FODMAP diet, how might we go about treating them without causing harm or further confusion about diagnosis? Well, there are a couple of dietary interventions that might be appropriate for your clients who don't fit the criteria for using the full low FODMAP diet, and we'll look at a couple of these. The first one is called FODMAP Gentle Diet. And this started about after 10 years of studying the low FODMAP diet. The creators of it developed a list of the most common high FODMAP foods that tended to be triggers for folks who were in research studies. And when using the the FODMAP gentle diet, only these foods that you see here are restricted during the diet. So it's a far shorter list than if you've run through the low FODMAP diet with clients. You know how long that list is. If you have the Monash app, it's, there's a lot of data there, but this keeps it simple with just the most common triggers. You can further liberalize the FODMAP gentle diet by instructing clients to try lactose-free dairy products so they can still have cow's milk and yogurt, because that removes the FODMAPs. And you can liberalize the grain category by sharing with your clients that while they're eliminating wheat and rye, they can still include real sourdough bread, because even though sourdough bread is made with wheat, the microbes in the starter feed off the fructans and make the bread low FODMAP for us, which is very generous of them. Here's another dietary intervention, which is called swapping or cherry picking. That phrase was coined by Patsy Katzos, who was the first US dietitian to use the low FODMAP diet with her clients in this country. So I want to give her credit for that, because it's something that that works really well. It's very individualized. So this would be reviewing a patient's dietary pattern and making individualized low FODMAP suggestions, removing certain things but giving substitutions in exchange. So for example, you could swap out high FODMAP nuts for low FODMAP nuts, so taking out cashews and pistachios and offering almonds or walnuts. And same with vegetables. You can take a meal that might be made up of Brussels sprouts and suggest mixed vegetables, which would lower the FODMAP amount of FODMAPs in that meal. Of course, again, this is done on an individualized basis, so you can determine what would be the least restrictive and least harmful to a client who is not a candidate for the low FODMAP diet or any dietary restriction, which is possible. For some folks, we don't do any dietary restriction or dietary intervention, especially like those I mentioned who have disordered eating or eating disorders. They may then go for help for their eating disorder, but they may still have their symptoms, or they're definitely going to have their symptoms from their GI disorders. And we can offer non-diet interventions that may be helpful and not trigger any maladaptive eating. So I want to review some of these alternative non-diet interventions for IBS with you. So the first alternative includes gut-directed psychotherapies. Some of these are gut-directed hypnotherapy, cognitive behavioral therapy or CBT, and mindfulness-based stress reduction techniques. These therapies are based in science and can really be helpful for your clients who have anxiety or stress as one of their triggers. So you might have tried the low FODMAP diet or the FODMAP gentle or cherry picking with your client and you didn't see a difference. And maybe it's because they've come to the realization, or if you've come to the realization, that stress or anxiety was a bigger trigger than food was. So you may tell them that they should try CBT. So CBT for IBS focuses on identifying and changing negative thoughts and behaviors that may be exacerbating symptoms. And it involves several components that you'll see there. So education is one of them, where patients learn about the connection between stress and IBS and how to identify the stress triggers. And then cognitive restructuring helps your patients to identify and challenge negative thoughts and beliefs that may be contributing to symptoms, like if I eat this, I'm going to be in pain, or if I don't get exactly 8 hours of sleep, I'm going to have a reaction, to reframe those thoughts. And then relaxation techniques are also used. So patients learn diaphragmatic breathing or deep breathing, or they can learn progressive muscle relaxation to help reduce stress and anxiety, or even meditation can be used. And behavioral strategies are also incorporated. So patients learn how to modify their behaviors in ways to reduce symptoms and avoid certain triggers, such as setting boundaries or avoiding situations where they know they get triggered. And overall, CBT for IBS is backed by research suggesting that it can lead to significant improvements in symptoms and quality of life, but it doesn't always work for everybody, and it's important to consider individualized care. But there is other psychotherapies that might work. Another one is gut-directed hypnotherapy. And it's a form of therapy that uses hypnosis to help manage symptoms of irritable bowel syndrome. And this therapy is based on regulating the connection between the gut and the brain. We know that IBS falls into the DGBIs, or disorders of the gut-brain interaction. So this kind of therapy helps with reconnecting the communication line between the gut and the brain. So in gut-directed hypnotherapy for IBS, a trained hypnotherapist guides the patient into a relaxed state and then uses suggestion and imagery to improve gut function and reduce symptoms. And this therapy typically involves several sessions over a period of weeks. And as with CBT, hypnotherapy can be effective for some, but not effective for all. And the other thing about psychotherapies is that it is necessary to see a GI psychologist or somebody trained in these programs specifically for IBS. And unfortunately, as of recently, the count was about 400 GI psychologists worldwide, which is not a lot of folks. But there are mobile apps created by GI psychologists and online programs that are good options and make gut-directed psychotherapies more accessible for the masses. So prebiotic fiber supplementation is the next non-dietary intervention, and prebiotics are not the same as probiotics, which I'll mention in a little bit, but prebiotics are non-viable dietary substances that stimulate growth of microbes in our colon and confer health, such as benefits to the GI tract, to cognitive functions, and to bone health. And the mechanism of how prebiotics works is that they provide sustenance. Those prebiotic fiber is the food that feeds our microbes, which then break down those fibers into short-chain fatty acids. And short-chain fatty acids benefit our body by playing a role in regulating our immune system and inflammatory responses, and maintaining and improving our gut barrier. So I like to explain to my clients that it's like fertilizer. So those microbes that need to be fed, that can grow and proliferate, and those that are have a solid colony and feel good don't necessarily need to feed off of it at that time. So if you see down here, I have listed that fructans and galacto-oligosaccharides are prebiotics, but they're also high FODMAP, and they may cause abdominal pain and gas and bloating for people with IBS, not necessarily for people without it. But a better choice of prebiotics are ones that are slow to ferment and won't trigger symptoms for people with IBS. So partially hydrolyzed guar gum, or PHGG, is a low FODMAP prebiotic fiber. In one study, it decreased symptoms and was shown to improve quality of life scores for those with IBS, constipation predominance, and diarrhea predominance during and after supplementation. And in this study, they used the intermittent amount of 30 days on and off. And again, not every client is going to respond well to this intervention. So if your client doesn't tolerate it, there are still some other options. A toileting regimen can be really helpful for people with IBS with constipation. So setting up a regimen each morning creates a new habit for those who don't necessarily feel or notice cues to move their bowels. And they will still have the opportunity to try, but without a long time spent doing so and without straining. So a bowel regimen can include drinking a warm beverage in the morning. Doesn't have to be coffee or tea, it can be anything warm. And what's thought about this is that it triggers the gastrocolic effect. So the gastrocolic effect is when you eat something or drink something, it sort of turns on the digestive system again to move things down in the system and get things moving. So we want to trigger that in folks with constipation so we can get things moving. The second thing that might help in a regimen is toileting positioning. So how your body's positioned while you are sitting on the toilet. What tends to be a good position is having your knees at a higher height than your hips. So having a stool under your feet or stacked books or even toilet paper rolls might help. I've heard of people overturning their garbage cans in their bathrooms. There's so many things that you can use. You just want to get your knees at an angle above your hips. And what that does is it helps to relax the pelvic floor, and that will help with elimination. Now, there are some people who have constipation separate from IBS or in addition to IBS, and they may have an issue with their pelvic floor function. And in that case, the relaxation alone may not help. And if that tends to happen, we may refer them to a pelvic floor physical therapist to help with that piece. But if it's IBS with constipation predominance only, then this may be very helpful. And while your clients are sitting on the toilet, they don't need to sit for more than 5 minutes. If nothing is getting started, then nothing's going to get started, and they shouldn't strain. We don't want them to cause, have hemorrhoids after that. So, but if they do feel a signal at another time in the day, it's very important that you explain that they need to make that signal a priority and find the time to use the bathroom, as holding it in will further exacerbate their symptoms. And using motility aids may be helpful as well, and I'll show you some of those on the next slide. So for those who struggle with constipation, motility aids may be in addition to the toileting regimen, maybe in addition to the prebiotics, maybe in addition to gut-directed psychotherapies, or maybe used on their own. It's really going to depend on who the client is. So the first one is magnesium. Magnesium supplementation is always an option. Magnesium citrate is strong, and it's what's used in colonoscopy prep. So when you tend to mention magnesium citrate, if they've had a colonoscopy before, they may be turned off by it because they fear that they're going to have the same experience as they did during prep, but it won't be the same. It's a much lower dose. But the forms of magnesium in the oxide or gluconate and hydroxide forms may be more tolerable, and they're definitely gentler. And magnesium works by drawing water into the colon and retaining that water in the colon. And it's a very safe micronutrient. So it has an upper limit of 2,000 milligrams or 2 grams. So what I tend to do with my clients, what you could try with yours, is starting your clients off at 250 milligrams and building up by 250 milligrams over the course of a couple of days if the initial dose isn't helping them, until they find that sweet spot where they're moving their bowels regularly. I typically suggest, and maybe you want to do the same, to take magnesium in the evening because it also has a calming effect. It is not it doesn't have a laxative effect if it's taken in small amounts, but if it's taken in high amounts, it can cause a laxative effect where people are going, relatively quickly. The next aid for constipation is psyllium husk fiber. It's a low FODMAP fiber that will also draw water into the colon and help bulk the stool and lubricate it, and it does not cause a laxative effect. You can find this in powder. You can find this in pills. It can be mixed into drinks. This is something that, again, won't cause a laxative effect, so it can be taken any time of the day. Fruit-based laxatives, like those that like prunes or dried mango laxatives, tend to cause some cramping and bloating and gas. But some studies have shown that kiwi fruit does not do that and is as effective as psyllium husk fiber. So 2 kiwi fruit a day have been shown to have a positive impact on constipation without symptoms. So you may have clients add 2 kiwi a day if they like them, if they tolerate them, if they can afford them, and possibly add it to their toileting regimens, having, kiwis in the morning or adding them to smoothies or having them, with lunch. Any way they want to have them. they're certainly helpful, and they've been shown to be a good help, and people like that idea. The last constipation aid is polyethylene glycol, which is the common ingredient in Miralax, and this will also, like psyllium husk, draw water into the stool and bulk the stool without so much as a laxative effect, but if a lot is taken, it can cause that. So following the instructions of their doctor will be helpful for how much they should take. There are also some aids for people who have IBS with diarrhea predominance. The first one is antidiarrheal medication, which could be helpful. One example is bismuth subsalicylate. That's not an easy word to say, but it's the active ingredient in Pepto-Bismol. There are, excuse me, headphone fell out. There are prescription medications, but I'm not a doctor. That's not my path, so I can't prescribe those, so I will leave that to doctors to share with their clients. Antispasmodics may also be helpful. Enteric-coated peppermint oil is one version that could help. So enteric-coated means that the capsule won't open until it reaches the small intestine, so it won't cause reflux symptoms in folks that have reflux. And taken before meals, these can help to reduce an overactive gastrocolic effect and calm the muscles of the gut so that there isn't so much urgency in bowel habits. This last non-diet alternative for IBS is the use of digestive enzymes. And I want to tell you a little bit about enzymes in overall, is that enzymes are proteins that act on food and have no impact on the body. So if you take them and you don't need them, they're not going to circulate in your blood and harm you. They're going to be digested and move on with the rest of the waste in your body. If someone is deficient in an enzyme, or if our body doesn't produce it, then digestive enzyme supplementations could not only improve an experience with food, but may also liberalize a diet further so that they'll be able to eat high FODMAP trigger foods without consequence. So, for example, lactose, which is the disaccharide that's found in dairy products. Our bodies do make lactase, and that's made on the villi of our small intestine. But many people, even people without IBS, can't tolerate lactose either after a certain age or maybe for most of their life. So it's a very common intolerance, and lactase supplementation can help. Using 9,000 units just before or with the first bite of food can help for up to 45 minutes and can be repeated if the meal lasts longer than that. It's easy to find. You can get it in a generic form if you'd like, or you can get it, there are brand names for it, and it's even found in Fodzyme. The next one is alpha-galactosidase, and this one breaks down some polysaccharides and is naturally found in the body in very small amounts and is also produced by microbes, but certainly not in enough amounts to make galacto-oligosaccharides tolerable for many people with IBS. So alpha-galactosidase is commonly found in products like Beano and can be taken before a meal to help with the breaking down of foods like beans and lentils. And alpha-galactosidase is also in Fodzyme. This last one that I'm going to talk about is fructan hydrolase, and it is not produced by the body, and it is only recently available as a supplement. And its job is to break down fructans like the ones found in garlic and onion and wheat. And it's a proprietary enzyme created by the research and development team of Fodzyme. And in one study, they found that 90% of fructans were broken down within 30 minutes of use. So that would certainly make some of the most common trigger foods tolerable by taking a digestive enzyme supplement to eat. And Fodzyme contains all three of these in one product. And how you use it is you sprinkle it on your food and then mix your food, or you can sprinkle it on the first bite of your food and take it all at once. And what it's meant to do is it mixes with your food and it starts to break down those FODMAPs as you're chewing and as you're digesting. And it does cover the bulk of high FODMAP foods. But it's important to note that there is an enzyme missing here, and it's something to digest polyols or sugar alcohols. And this doesn't currently exist. I wish it did because it's one of my triggers. The research and development team of FODzyme is working on it. So stay tuned for when that becomes available and further liberalizes diets. So if you're using enzymes in addition to dietary interventions, you would still have your clients follow the low FODMAP elimination phase and then advance to reintroduction. This way, they'll know exactly which foods are their triggers, and they can either choose to avoid them, or they can use enzyme supplementation to help when trigger foods are known or not known. So if a client is going to an event like a wedding or a buffet and they don't know exactly what's in every food they put on their plate or that's served to them, they can sprinkle FODzyme on, and it can be covered, or whatever the enzyme is that they're using, and feel safe eating that food, safe from symptoms. So using digestive enzyme supplementation allows them to eat the trigger foods with very little consequence or no consequence during the personalization phase. And then if a dietary intervention is not suitable for your client, if you have somebody who has an eating disorder and you cannot do any dietary intervention, or if somebody's not willing to make a change, there are two options here. And one is to use the enzymes when they are knowingly eating food that contains lactose or galacto-oligosaccharides and fructans, or if they're already aware of where to find FODMAPs in their foods. So if they're at a place in their eating that's appropriate to share the app with them or lists with them so that they know which foods are high in FODMAPs and which foods are low in FODMAPs, then they would know when to use the enzyme. But they can also use the enzyme without having any knowledge of FODzymes and just use them regardless of what they're choosing. And this way, it's helpful for people who are either not educated on the low FODMAP diet or the content of food. And it also would cause a negative impact to disordered eating behaviors should a person have to have lists of foods that are either tolerable or safe, or whatever term is used when you explain this to them. So not having any knowledge of it and using the enzymes is a good way to help with managing food triggers for people who are not candidates for a dietary intervention at all. So some of you may be wondering why I haven't mentioned other possible non-diet interventions, including the ones you see here. And the reason for that is there's just not enough evidence as of today to recommend these interventions. So while some may work for some, and you might find clients that say acupuncture works for them, that's great. If it works for them, it works for them. That doesn't necessarily mean that it's translatable to all people with IBS, but if something's working for somebody, they can certainly continue doing it. But the reason why we would avoid some of these things is because either the studies were small or inconclusive or not evidence-based, but there are also some recommendations that are against some of these things because of the evidence that's shown. So for example, according to the ACG, which is the American College of Gastroenterology, they have a clinical guideline for the management of IBS. They state that probiotics and IgG food sensitivity testing are not recommended because there's not enough evidence that either offer improvement, and the IgG food sensitivity testing can lead to further unnecessary restricting. So those are cases when we wouldn't recommend them. But in the case of probiotics, I've certainly had clients come to me and say their probiotics work wonders for them and they want to stay on them. And if it's not making them feel bad, they certainly can stick with them. It's their body. They can decide what they're going to put in it. I'm all for that. the other thing is that according to another agency called NICE, the NICE guidelines, NICE stands for National Institute of Health and Care Excellence. It's basically the USDA of the United Kingdom. They recommend taking probiotics for 4 weeks and monitoring if there's a response. But that recommendation was made in 2008 and hasn't been updated. So you can either go with the ACG or you can go with NICE, or you can have your clients decide what they're going to do. And if they have symptoms, then you tell them that they can stop using it. So I want to share with you some takeaways from today. So first, before choosing a dietary intervention, screen your clients for disordered eating and maladaptive eating patterns. I shared with you a few screening tools. There are others. There's SCOFF, there's Ellen Satter's ECSI 2.0. There's a number of them. Again, there aren't any that are validated for use with eating disorders and GI disorders, but it will give you a clue into eating behaviors and relationship to food, food acceptance, eating regulation, things like that. The second is that there are options for dietary interventions. You don't have to use a low FODMAP diet just the way it is. There are the FODMAP gentle, there's cherry picking, many ways you can do it. Third is that there are non-diet interventions that can be effective tools in managing symptoms for those that are not appropriate candidates for dietary interventions. And those tools can also be used alongside dietary interventions as well. So sometimes the more the merrier. See what works, try a bunch of different things. There are options. And the fourth is dietary enzymes can be used to liberalize the personalization phase of the low FODMAP diet once the food triggers have been identified. And lastly, the enzymes can also be used to eliminate the need for a dietary intervention altogether for those who are not appropriate candidates for the low FODMAP diet. I want to leave you with some resources for further reading about IBS and other disorders of the gut-brain interaction that you might encounter. So there are some directories here where you can find GI dietitians and GI psychologists, gastroenterologists, and even pelvic floor physical therapists. These are all important members of an integrative care team. Some of these sites also have useful patient education materials as well. So take some time to check these out and see what you can see and learn as much as you can before working with folks with IBS. And I will turn it over to Jocelyn now to ask me the questions that you have posted during this session.
Wonderful. Well, thank you, Beth, for so much important, valuable information. I know I, for one, am so glad that this is being recorded because I definitely want to go back and reference all of that to make sure that it really, really soaks in. We have wonderful, incredible questions in the chat. I can kind of already tell that we might be up at time, but we'll get to as many of these as possible as we can within the hour. So we'll start more or less in the order in which they came in. So our first question here is from Beth asking, would you say someone fits the Rome 4 criteria if they report bloating rather than pain at least once a week? I know the criteria says recurrent abdominal pain for at least 1 week, but I have a lot of clients just reporting bloating more than pain.
So the Rome 4 criteria mentions pain first. So there's pain can be subjective. It could be discomfort, and bloating alone might signal something else besides IBS. You could have pelvic floor dysfunction, and there's one called abdominophrenic dyssynergia, which is a dysfunction where the muscles that help with moving your bowels and digestion are no longer coordinated. So it causes lots of bloating. That's the people that might come to you that say, I look pregnant after I eat. That might be an issue. So if the doctor hasn't been able to diagnose IBS based on the Rome 4 criteria, there might be a need to go see a pelvic floor physical therapist and get treated for pelvic floor dysfunction.
Thank you. Great. We'll go to our next question. So here we have a question from Susan on if you react to one food in a FODMAP category, will you react to all foods in that category?
Not necessarily. So especially in the fructan category where you have your garlic and onions and wheat, the amount of fructans that are in each of those foods differ in concentration. So you might do fine with one or the other, or you might have trouble with all three. Can't really tell unless you try them. But in some other categories, if you try one or two foods, it will give you a good idea. So for something like excess fructose, if you were to try honey over a teaspoon or mango and you did well with both of those, most likely you do well with foods that have excess fructose in them, since those are pretty high amounts in those foods.
Great, thank you. Really helpful. Our next question, so we have a question from Angela asking about any books or other resources you could recommend for those who want to learn more about how to go on a low FODMAP diet. So maybe in addition to some of the resources we shared, if you have favorite books or, websites.
Yeah. FODMAP Every Day is a great website. Monash has a great website. Kate Scarlatta, who's a GI dietitian, has a great website. I certainly wouldn't suggest for people to go on a low FODMAP diet on their own. I really believe that working with a GI dietitian, and that's actually been in the research, that people do better on it by working with a dietitian than doing it on their own. So I would suggest looking for GI dietitians. You can find them on GI OnDEMAND, on IFFGD, which was one of the links provided in the resource slide. So that's what I would suggest.
Great, thank you. Here we have a question from Beth, for Beth. Would pregnant women be a candidate for the low FODMAP diet or not? What about children?
I don't know that I would put a woman who is pregnant on the low FODMAP diet. I don't know that it's been studied specifically about pregnant women. But my feeling is that we want to have as diverse a microbiome as possible. And when we go on the low FODMAP diet, we are limiting our prebiotic fiber intake at that time. So I would tend not to do that and try some of the non-dietary interventions, or do some cherry picking rather than doing a full elimination. As for children, I wouldn't put children on any sort of restrictive diet, with the exception of just some rare instances like type 1 diabetes and certain ones where they have food allergies, of course, because it becomes restrictive. It makes them think about food as good or bad. And I certainly wouldn't want children to have an understanding about categorizing food like that or being fearful of food.
Yeah, absolutely. Great. Thank you for answering that. Our next question we have from Angela, stating, I work with older adults and their families, about over 50 years old. Is IBS more prominent as we age, or is it not age-related?
That's a good question. Older adults. I'm an older adult according to this. So, and I have IBS, but I got it before I was an older adult. It's a good question. I'm not sure if it's just more prominent in older adults, or if people in their 20s tolerate pain better than people in their 50s do. But we do see it somewhere between the 20s and the 50s being diagnosed. We also see it 2-to-1 ratio of women to men. Might even be a little bit higher. I think it's like 80% is women at this point. We don't really know how we get IBS. One thought that's coming to mind or coming up in the research is either foodborne illnesses or like a stomach bug. Gastroenteritis can cause it. It may be a change in our microbes or our microbiome, and that's new research that's happening. So that's my thought. I don't know that it's necessarily age-related.
Yeah, thank you. So many open questions about the pathogenesis of IBS. I know we're all
still, right? Yeah.
Always hoping for more answers.
Mm-hmm.
Our next question here, this is technical. So let's say I have a client that had maltose malabsorption. Should I put them on a disaccharide-free diet, or is there a way to single out maltose?
So that's different than than IBS and low FODMAP diet, maltoses and starches. So it's a different sort of diet. You can try to reduce maltose intake, but it's everywhere. And there is no enzyme for that yet, but maybe we can talk to the FODzyme folks and maybe they can create an enzyme for your client and help them that way. I guess my answer would be, I think that would be difficult, but you can certainly work to do some cherry picking with them and find some foods that are lower in maltose they may tolerate better. Thank you.
Great. That's helpful. Our next question about the toilet regimens you shared, and also a little bit outside of the scope of IBS, but asking, is this also helpful for IBD colitis with constipation?
So the toileting regimen was for people with constipation, and typically people with IBD colitis don't have constipation that I've seen in my practice. It certainly could help. It won't harm if people are experiencing constipation, but also with IBD, that's a structural disease where there could be obstruction, there could be blockages, there could be scar tissue. So if someone's struggling with constipation with IBD or colitis, then I would also possibly reach out to my doctor to be scoped or to have some testing done to see if it's functional or if it's structural. People with IBD can also have IBS, so it's important to get diagnosed with everything. Unfortunately, it can be more than one.
Thank you. Yeah, so many questions. Great. Here we have a question looking for a favorite brand you might have for the partially hydrolyzed guar gum.
I don't know that I have a favorite brand. I have a couple of brands that I like. I mean, guar gum is guar gum, as long as there's no other ingredients in there that are high FODMAP. You want to watch out for something like inulin or chicory root extract. Those are high FODMAP prebiotics. I tend to lean towards Sun Fiber or Regular Girl. There's one on Amazon called Perfect Pass. I just like it because it's a funny name. But you could choose any of them.
Great, thank you. Here we have interest from Emily, and is there a study to show a warm liquid can promote the gastrocolic effect?
There are. I think they are in the reference section of these slides. I don't know if that will come along with the recording, but I can. You can certainly reach out to me on social media, and I can send you a link to a resource.
Great, thank you, Beth. Here also in the supplement vein, we would like to know, do you see success or challenges with milk of magnesia as an IBS constipation intervention?
You can use it. It has magnesium in it. I find magnesium supplementation alone works best, and also doesn't have the same flavor when you're taking a pill as when you're drinking milk of magnesia.
Great, thank you. So here, we have a question from Robin around SIBO as well. So she's saying, can you address low FODMAP and SIBO patients? Some of the food reintroduction would feed the bacteria. So would you always keep those foods off the patient's diet intake?
So SIBO, which is small intestinal bacterial overgrowth, is when your small intestine has that bacterial overgrowth. So where bacteria doesn't belong in your small intestine can overgrow. And it doesn't necessarily happen on its own. It's usually secondary to something else. Typically constipation or a high stool burden can lead to it, or a muscle weakness or deficiency in the migrating motor complex, which is like the wave-like sweeping motion of the small intestine that clears it out after the contents have been emptied into the colon, the large intestines. But I think the most recent data shows that 60% of people with SIBO have IBS. So that's where I would use the low FODMAP diet. SIBO itself does not have a dietary intervention to date. So somebody with SIBO may or may not benefit from using a low FODMAP diet. So there aren't any foods that I would stop from reintroduction because it's not necessarily the food that's feeding the bacteria, but it's the lack of the intestines emptying or waste hanging around a long time that can cause that growth. And I would tend to send people for for antibiotic treatment at their GI doctor first to see if that works. That's really the best way to get rid of the bacteria to date.
Yeah, absolutely. Thank you.
Microbes, yeah.
Here, our next question is around how effective has FODZIME been shown with tolerating garlic? Do we have any stats?
Well, I can have Angie or David answer that question, but I can tell you, anecdotally from my clients that have used it, they're tolerating their fructans very well. For those that don't have like a gluten intolerance, which would be the protein in wheat, not the carbohydrate in wheat. So I don't know if Angie or David have any information on that.
Thank you, Beth. Yeah, I think that's an excellent point. I'll just add on top of that something that you've already mentioned, which is our first peer-reviewed publication. That study that we did about a year ago, but was published a few months ago. And that's where we showed essentially that one dose of FODZIME can efficiently degrade about 3 grams of inulin to about 90% within 30 minutes. It's important to say that because basically that's the main FODMAP in garlic. By weight, that's about 30% of the garlic itself, and 3 grams of inulin corresponds to roughly 6 cloves of garlic, just to give you an idea. And so, that's more or less the ratio that we're seeing on FODZIME dosage, and how it can very well target inulin, for instance, in garlic and obviously other foods.
6 cloves is a lot.
It is.
Yeah.
per meal, per person, yeah. But you do you, whatever feels good.
So we have another question here on peppermint oil for urgency. So wondering if you can share any more research on this.
Yeah, again, I have references for that were listed at the bottom of the slide. So when you get the recording, you'll see where I reference these. But again, if you want the specifics and you don't have you don't have them, then I'm happy to send that off to you. But what it does is it works as almost like a little bit of a muscle relaxer. So it stops the peristalsis from being so urgent. And that's how it reduces urgency.
Great, thank you. Here we have a question on, is there any research or clinical guidelines that show that an eating disorder screen should be done prior to a GI intervention, or at least that it should be done concurrently? Yes,
I believe the ACG published an article on clinical guidelines for eating disorders and GI. I don't know it offhand. But they have a journal and it would be in there, and I believe it was in 2022.
Great, thank you. So here we're asking if a patient doesn't tolerate fructose, will using fructan hydrolase lead to symptoms? Great question. Thank you, Rita.
That is a good question. I'll pass it off to the FODZIME folks to answer that.
Sure, I can jump in here. Thanks, Beth. And hi, everyone. My name is Angie. I'm one of the co-founders of Kiwi Biosciences, the company behind FODZIME. So to back up a little bit, fructose is a little bit different from the rest of those FODMAP triggers, and it's that it's not the mere presence of fructose that tends to trigger symptoms, but usually excessive fructose, excess of the glucose balance. And recent clinical findings have shown that typically that threshold level to trigger symptoms is a lot higher, arguably an order of magnitude higher than those the threshold needed for triggers like fructan or GOS. And so that small amount of fructan in relative to fructose, the fructose threshold in most meals that you would be using fructan hydrolase on would be just minimal compared to that kind of fructose threshold. So generally no, but if someone is very sensitive to fructose or has like a hereditary issue with fructose intolerance that's separate from a FODMAP issue, they should be perhaps steered away from such a method. Hope that helps.
Great. Thank you both. Yes. Here we have a question on polyols. So what are some common foods with polyols?
Well, polyols are sugar alcohols, sorbitol, mannitol, and xylitol. Mannitol common foods would be mushrooms and cauliflower. Sorbitol you would find in apples and pears, and also in some candy. Xylitol is in candy and gum. The sorbitol, of course, is not on the label of an apple, but you would find it used as a sweetener in as like a artificial, it's not artificial, but artificial sweetener. It's a non-calorie sweetener in some candy, some of the sugar-free candy that's on the market.
Great, thank you. And I know we are out of time here. We'll try to get to the last few questions, and then we'll follow up with any we don't get to. So we have a question from Mary Lynn on what are your thoughts on potential low GI HCl and HCl supplements?
So those wouldn't really be used for IBS. Those are typically used for either reflux or people who are deemed to have low acid in their stomachs. I haven't seen data to warrant using the like betaine HCl in research. So it's not something that I typically use.
Great, thank you. And I'm going to make this our last question, and then we will get to the rest via email. So we're looking for the best place to find ACG clinical guidelines for managing IBS.
Yeah. They are in my references, but you can Google it. It's a free article. There's no paywall with them.
Yeah, that's great. So wonderful, and thank you all so much for taking your time to join us today. Thank you, Beth, for truly sharing your wealth of knowledge with us.